Okay, welcome everyone to the launch of the report today. My name is Brian Omala and I'm with Haki Jamii. Thank you all for joining us. We were not able to hold physical meeting to launch this report, and this is because of the COVID-19 situation in the country. As you can see, we are here in studio and we are keeping social distance according to government directive that was issued some time ago. So I really want to thank everyone. Please stay with us. For those who are joining, kindly make sure that your audio is on mute so that we can have meaningful engagement. Also, just make sure you're using the chat box as we dive into the discussions. You can already start asking questions that you'd like our panelists to tackle. And if you wish to talk, kindly raise up your hand. I think there's something, an icon to help you to do that, and we'll be able to see you from our end to give you that opportunity to talk. Now, I'll give a little bit of background on the launch that we are doing today before I welcome the very able panelists that we have today. So Debunking Public Health Puzzle was commissioned by Haki Jamii sometimes last year. I think it was in December last year. And it majorly did 4 things that I would like to quickly mention. One, it provided an assessment of the factors that hinder enjoyment of health as a public good within urban informal settlements. Number 2, it provided an assessment of the policy, structural, and administrative gaps that currently exist in the healthcare system. Another point, it determined quality and scale of private vis-a-vis public healthcare that currently exists in these informal settlements. And also it provided some very practical recommendations on actions that governments and various stakeholders can take to make sure that UHC is being rolled out in a very inclusive manner and that it achieves the intended objective. Now, the report was done in 3 informal settlements in Nairobi and Mombasa. One was Kibera, 2 Korogosho, both in Nairobi, and then Kisauni in Mombasa. Now, if you, I'm sure most of you have had time to go through the report. Of the people that live in urban areas, 56% of this population reside in urban informal settlements. Now, these are very disturbing figures because 36% of this population do not have access to clean, safe, and quality water within their compounds or in their households. You will agree with me that this is a very high number. Kibera alone, where we have almost 185,000 people who reside in this area, have almost 70 healthcare facilities that are registered, and only 3 of these are run by the Ministry of Health, according to the report that we are launching today. Now, the patient ratio of the doctor to patient is 1 to 2,000. 1 to 2,000. This is very disturbing as well. And there are a lot of challenges that exist within these informal settlements. One, an affordability and accessibility, and even the quality of the services being provided in these healthcare facilities are wanting. Now, this is largely due to the failure of NHIF to meet the needs of the vulnerable populations within these informal settlements. Now, this has led to the rise of private healthcare facilities, which are not only affordable, unaffordable, but they are also unregulated. And so they provide very poor services. Now, this has also led to emergence of NGO-run facilities and other faith-based organizations that are within these areas. But this is not enough, because you find that in these areas, there's a lot of people, very large populations. And as we have seen in the case of Kibera, where one doctor or one healthcare provider serves almost 2,000 people in these areas. Now, the good news is that the government of Kenya currently is very committed to scale and roll out UHC, and this is rightly embedded in one of the big four agenda that has been prioritized by the Jubilee government. It's also in one of the SDGs, and specifically SDG number 3, goal 8. So there's hope at the end of the tunnel, and we hope that UHC will be rolled out in the manner that it will help or assist people to reduce out-of-pocket healthcare spending. Now, I'll talk a little bit about the report that was commissioned by Haki Jamii, and Pauline will talk more about what Haki Jamii tries to do and the work that we currently do to make sure that there's social accountability, promotion of social accountability, especially in the health governance, mostly in the informal settlements. Now, the purpose of this report was to gather policy perspectives, and I'm sure Omondi will talk more about this in his presentation, but I'm just giving some background. The report was commissioned to gather policy perspectives, active community voices on access to healthcare within informal settlements, with the overall intention being to inform policy review, advocacy, and programs that aim to increase access to quality public healthcare in the targeted informal settlements, and not only in these informal settlements, but also across the nation. Now, I'll take you briefly through the agenda today. We'll have welcome remarks by Pauline, who will formally invite us to this session. And then we'll have the report presentation, of course, by Omondi Otieno. After that, we'll have our panelists give their reactions, their initial thoughts to this report. And then we'll have round 2 questions based on those reactions, after which we will open it all to our participants to also ask questions. I would like to now briefly introduce our panelists. We have number 1, Betty. Betty Hamoud is known as Mama Kenya, who is here with me today. Betty, you can just say hi.
Hi.
Thank you, Betty. So Betty is a human rights defender at Westlands Watch for Peace, Gender and Development. This is a grassroots organization defending human rights. She's also an advocate for gender-based violence from the Westlands GBV Working Group and patron of Westlands Informal Settlements Association. Very much welcome, Betty. We are glad you joined us today.
Thank you very
we
much.
have next Lucy Nyambura, all the way from Mombasa. Lucy, hi. Lucy is a trained public health officer coordinating universal health coverage under Transforming Health Systems for UHC project in Mombasa County. She's also a member of County Health Management Team with over 23 years experience. She's a member of the Catholic Archdiocese Emergency Response Team and has also participated in the development of Mombasa County Social Protection Policy that I understand was also led by Omondi Otieno. So thank you, Lucy, for joining us. Next, we have Pauline Vata, who is also here with us today, who after this will formally welcome us and give initial introductory remarks. Now, Pauline is a human rights defender and advocate of the High Court of Kenya, and she is also the executive director of Economic and Social Rights Center, Haki Jamii, that is hosting this launch today. So welcome so much, Pauline. We are glad you are here with us today. And next we have Omondi Otieno. Omondi Otieno was the one taking lead in this report, and he will just take us through the findings, some of the recommendations that the report came up with. And Omondi is the Managing Director of Capacities for Health and Social Policy. Thank you, Omondi, for joining us. Lastly, we have Betty Sharon. Betty Sharon is also joining us from Mombasa. She's the founder and executive director of Collaboration of Women in Development. This is an NGO based in Mombasa.
Hi.
Hi, Betty.
Hi.
She is also the founder Pwani Gender-Based Violence Network and also gender advisor on World CSR Council. So we are very delighted to be joined by panelists who have very diverse experience and will be able to talk more about our discussions today, and especially with the emphasis on UHC, and discuss more about some of the recommendations that the report issued. So up to there, I would like to thank you all. Please stay with us until the end if you can. And now I'll take it over to Pauline to give her introductory remarks.
Good morning.
Good morning.
I'm really happy to see you all. Welcome to this virtual conference. I can see we have participants from Mombasa, Nairobi, Kakamega. I'm very encouraged by your participation, and I really look forward to have quite an engaging session. I would just like to highlight what Haki Jamii does for those who are new in this forum, or for those who have not engaged with Haki Jamii before. We are a national human rights non-governmental organization. We have our offices in Nairobi, but we work in 7 different counties in Kenya. Our core area of work is socioeconomic rights, and particularly we are known for forced eviction and land and housing rights, but we've also gotten into health rights, particularly on issues of accountability, governance, and now we are looking at public and private health facilities in informal settlements and how those respond to marginalized communities. So I am very happy with the work that Haki Jamii is doing, continuing to promote socioeconomic rights in Kenya. We all know it is not easy to adjudicate, to advocate for socioeconomic rights, because there's always that lingo that they are progressive, we cannot have them now. Even if you have private health facilities in informal settlements, government says, but we have one in a certain settlement that can serve X number of people. So this report really is to help us understand better how can government respond to marginalized communities living in informal settlements, while at the same time preventing too much privatization of facilities within informal settlements or within areas that are of low income. We all know that a right to health means that everybody must have access to the highest attainable standard, but that has not been the case to date. We have our constitution, but it is yet to be operationalized fully, and especially on socioeconomic rights. Unlike civil political rights that are immediate, socioeconomic rights are progressive. And so it has been quite a challenge, really, to sort of hold government to account per se on what they have not been able to do, because they also say, but we have provided X number of facilities somewhere, and that is the budget that we have for now. So this report is sort of like an eye-opener for Haki Jamii and for all participants in this virtual forum and the consumers of this report. And the report on debunking the health puzzle, and Brian has already said and highlighted some of the factors that led us to do this research, but I will highlight just a few more factors that we found out when we did this report. It provides an assessment of the factors that hinder enjoyment of health as a public good, particularly in urban informal settlements. So you might wonder why we chose urban informal settlements, but our core work is within urban informal settlements, and most people who are low income and the very marginalized and vulnerable community live in urban informal settlement. So we did the research in Kibera, Korogosho, Kisauni, and one of the things that we found out was there's an issue of accessibility and affordability. I think it's not a secret that public healthcare facilities are inaccessible to many in the informal settlements, given the limited number and proximity to these particular settlements. For instance, Kibra, which is one of the largest informal settlements in Kenya and has a population of 185, according to the 2019 population population housing census, 185,000 people. It has 70 registered health facilities, which implies a health provider to patient ratio of 1:2,654 for majority of the level 2 facilities. So of the 70 registered health facilities in Kibra, only 3 are run by Ministry of Health. So you see there's an issue here. If the ratio in Kibra is 1:2,654, as we all know, during this period, we're in the COVID-19 pandemic. So what if we'd have, an explosion like what we saw in Italy or USA, and you have a ratio of 1:2,654, it will be chaotic. And so what we're trying to say is that as much as these rights are progressive, there's an immediate need for government to put in more resources in terms of staffing, in terms of having adequate budgetary allocation to go to health facilities, to have more physical centers coming up that are well equipped, because in the event of a pandemic or in the event of unforeseen circumstances, then we cannot be able to properly give all citizens the healthcare that they all deserve. And this would be detrimental to the population. Brian talked about NHIF. And in the report, NHIF it's like the primer to UHC, if I would say. I mean, if you ask government what is UHC, they would say NHIF. And what is NHIF? NHIF is equivalent to UHC. So we were looking at NHIF and whether it has been able to respond to issues of quality and affordable health services to the needs of the vulnerable populations. And we found that the rising private healthcare facilities, particularly in informal settlements, which are commonly unregulated, one, they offer poor quality services, they're exploitative, they're run with a profit motivation, they take advantage of the macroeconomic culture in informal settlements. So as much as you have an HIF and you live in a settlement, the settlement does not have a public healthcare facility. So you still have to go to a private healthcare facility that one charges exorbitantly. So even if you have NHIF, you won't use it to the max as much as what is in the policy document for NHIF. So you have health insurance, but you have no facility to go and utilize your health insurance facility, your health insurance in. So you end up going to either a quack in some of these settlements, or you go to a substandard facility that does not offer the correct diagnosis or does not respond to the needs that you have as a patient. So yes, you have an HIF, but it does not help you as much as it should. So what the study really is saying is that healthcare as a public good is a mirage to informal settlement dwellers, given numerous factors hampering access and affordability. And these factors, Omondi Otieno will highlight in depth, and will also have Betty Sharon, will also have Lucy come in to highlight some of the challenges, and her from the county government perspective. She'll maybe highlight some of the issues that government is trying to address when it comes to providing quality public healthcare in informal settlements. So really, it is crucial that as we continue deliberating on aspects of healthcare, especially in informal settlements, of public healthcare, we need to look at what is the plight of the very marginalized and the vulnerable communities, and even whether our engagements and whether our responses really resonate with this particular group of people, because it is not enough for government to launch projects, for government to launch facilities, and they do not respond to the very vulnerable communities. So yes, we have policy documents. NHIF has many, many policy documents behind it. We have UHC, we have all these things, but are they responding? You know, are citizens coming up as active citizens to hold government accountable, maybe through civic engagement approaches or whatever other approaches that are out there? So these are things that are very dear to Haki Jamii, and we really like to hear your feedback and how we could engage further using this virtual platform, how we could make the report better, how we could execute it better, because it's just a report. So what will come out of it is actual deliberations, either with policymakers, with the community, for them to be able to address some of the challenges recurring. And it is not just enough to say we need more budgetary allocation. Yes, there's been more budgetary allocation, but there's also corruption. So we also really need to look at all these factors that hinder healthcare from a broad-based perspective. Otherwise, I wish us a very engaging virtual session today, and I look forward to your engagements and to having you all to the end. Welcome, and looking forward to your further comments and input. Thank you.
Thank you. Thank you so much, Pauline. I think you have kind of set the pace for the discussions that are going to take place today. And I do agree with you that it's not just enough to do a report. We need to ask ourselves, then what? Even as we try to discuss this report. So what next after the launching, you know? So thank you so much, Pauline. Now, I would like to invite the next speaker, who is Omondi Otieno, who is now going to take us through some of the report findings, some of the recommendations, as well as some of the things that maybe stood out in this report. So thank you so much, Omondi, and go ahead and take us through the report.
Okay. Thank you so very much, Brian, and of course the entire team at Haki Jamii, and of course, I'm happy to see the rest of us. Happy to listen to Pauline always. Happy to see Lucy, just like you mentioned, Brian. Lucy and I have worked on a number of things down in Mombasa. Happy to see Betty and the rest 42 of us who have joined. I have shared my screen. Please confirm, Brian, at the very least, if you're able to view.
Yeah, that's perfect.
Okay. So I have about 20 minutes, give or take. I mean, basically to present what would otherwise be in a 50-page report. So I have tried to organize the presentation into I mean, just some core takeaways, some really some messages that I think could resonate well with us. So yes, I will try to really be snappy, but of course, feel free to indulge me at the end of the presentation, and most importantly, feel free to also take time to engage and look at the report. It has a lot more detail, most certainly, than we will be able to share. Brian and Pauline have done a really good job at my presentation. They have already, dived into some of the issues that we possibly picked up, challenges of access and quality, of course, challenges with UHC and the manner with which we equate, NHF and a lot more. And I think what I will do then is just to put that better context to that conversation that they already have started. Yeah, so so basically, my presentation will be organized into 4 sections. One would be just a quick overview, and I will probably spend a minute or two talking about the process. In any study, it's really important that you understand the manner with which we arrived at and obviously generated the recommendation. So I will just be able to spend about a minute or so on that. Then I will talk about the context. I mean, everything else, the provision of healthcare, is even for urban informal settlements, definitely a broader policy context and structural context. And I think I will be able to speak to that a bit. Some of that context is equally behavioral and even socioeconomic. Then, of course, highlights of findings, and in the end, what Pauline says, what are those core takeaways, or either Pauline or Brian. So where we're saying, listen, this is, so what, right? Where do we want to go from here? What are some of those things, actionable pointers we can actually, move forward from the report. So yes, I will probably just, that is how I will organize this. Please, my request is that take notes, pay so much, the much attention that you can, and allow me to present to the end. And so then it's after then that we could be able to ask questions. But of course, if you have something that is snappy, something that is really, you think we should not, then feel free to raise your hand and drop a chat. I'm sure Brian will be able to pick that up. So yeah, thanks. Now, in terms of the purpose of study, we Brian talked about this. So the idea was to establish the policy and structural and administrative gaps within the public health sector that hinder access to quality health services by the marginalized community in the informal settlements. I mean, the whole idea here is to understand the organization of healthcare and whether the manner with which that system is organized in itself perpetuates, some forms of marginalization, on whether there are aspects of institutional arrangements within the healthcare system that basically, in the end, to lapses in service delivery. So, and of course, with particular focus to informal settlement. So that was, sort of like what we looked at on objective 1 of the study. Objective 2 of the study looked at the elements that propagate private healthcare provision in the informal settlements. Again, this was rising from the fact that, listen, there are a lot and lots of, private health facilities. Healthcare provision in informal settlements is actually dominated by private players. The question is then why, right? What is this opportunity? What is this that they see that the public healthcare system is able to step up to, and what exactly are the issues? Are the issues in there from a demand side, in which case then based on attitudes of populations in those regions, or is it from a supply side, which means weaknesses in delivery systems? And then, of course, in the end, having picked up as much data as we could from objective 1 and 2, then that's meant to lead to, what I just said. So highlight specific actions the government should ensure inclusivity and success of universal healthcare, of the universal healthcare agenda, and of course with particular the marginalized groups within the urban informal settlements. This is basically, textbook approach to lots and lots of studies. Inception, which is where we have built clarity on the study. We develop hypotheses, we develop the research questions and clean those up. We develop a plan, we have clarity of key informants, we develop approach. So that's basically the step 1. Step 2 talked about, is where we, of course, now set out to review reports and policy, existing policy documents relevant to the study. Frameworks and all the planning documents that there are, quite a number of those. Step 3 is where we talked, where we basically looked into, gathering data, and this was predominantly a qualitative study. So that means then we engaged with in this informal settlements, and obviously certain key actors, of course, at the macro and meso levels. And then all that put together led us to step 4, where we then now try to make sense of the data that we have gathered, and of course through desk review and through raw qualitative data. And then of course that involved analysis, reporting, and most importantly there was validation where opportunity was provided for triangulation. Either from teams at Hakijami and obviously from from the populations that were targeted by the study. In terms of the limitations, the study applied qualitative approaches. The findings and conclusions have therefore been generated through non-statistical inferences, and what that means, therefore, is that you will not see anywhere in this study. It's very devoid, many the numerous percentages and ratios, other than those that we gathered from already existing studies. So this was purely, gathering perspectives from all those involved at the community level, and of course amongst actors. As a result of that, it is possible to just point that some of this data you could find in the larger report a little generalizable, because you would find situations, I would say, roughly, if we're talking about doctor to patient ratio, you might easily find statistics available for the country or for the counties. You might not then find those very accurate to the specific informal settlements that we had in mind. But nonetheless, I think we did the best that we could, some forms of meta-analysis to try and refocus to the target audience as much as we could. So in terms of the context, delivery, like I said, is happening within a space, and looking at governance, of course, we have national government versus those of county governments, and we know that this was off to a really turbulent start, of course, upon the devolution. But it seems like the wheel is beginning to turn, albeit smoothly. We're not. I think the sharp divisions between the roles and responsibilities of national government, and sometimes most likely what could have been seen as an overreach of the national government. I think that it seems like some balance is getting created. Has that form of balance resulted into improvements of service delivery just yet? Depending on how you look at it, I think it is important to understand that we are on a path Of course, the journey needs to be appreciated, but there's a lot more that could still be done, as we will be able to highlight in report. Of course, there is existence of different guiding policy documents, strategy documents that basically inform actions in health, looking at health sector strategic plans, and these are a lot of counties have done extremely well on this. So you have county health strategic plans all over the place. I don't know a county that does not have a strategic plan level. But as to whether or how well it is implemented, I think that remains highly debatable. We have community health strategies, and there's a clear community health strategy, which I think sort of like anchors lots and lots of primary healthcare work. These documents exist, and they have to quite some acceptable quality. We have county integrated development plans, and lots of county governments have done extremely integrating or prioritizing healthcare within their CIDPs. You have the national health policy, you have the national act, you have all these, documents, documents available. Fidelity to the implementation and the extent to which they have integrated special provisions, which populations definitely still remain to be explored. So in terms of the, a lot of us, I'm sure, are familiar with this, but I take it that maybe some of us are not from the mainstream, health background. And nonetheless, this is how the healthcare system is organized, at the floor of services at the very least. So you have level 1 to 6, and the national government is predominantly responsible for, what is referred right there as tertiary the referral facilities mainly, and there's just a handful of them in the country. The county government is then responsible. Of course, you still have lots and lots of vertical programs managed at the national level. Vertical programs, programs like the expanded program on immunization. You have malaria programs, you have TB programs, and right now IDEA are COVID. Basically programs whose execution is primarily driven by a carefully controlled national level protocol. So those are still very much the premise, under the armpit of the national government. But then the government does all those. So just a quick, this wasn't really purposed to be a healthcare system. When that time comes, we are able to look at, with substantive detail, what is human resources for health, what is the nature of, infrastructure in health, what is the nature of, procurement and everything else in health, and we can look at all the pillars and MIS and the rest of them. But since that wasn't the purpose, the idea here is then to just run through what some of the issues could be. Human resource challenges. And I think this has been spoken to quite a bit. It's not the first. Turns out this is not the first study that we're conducting for for Haki Jamii. In a previous study, I remember that we had in Kakamega, we went. I can never ever forget this. We went to some facility where you would have it was a dispensary that they have gloves, for example, and so you would have instances where patients would be sent out to go and get gloves. But that wasn't quite the issue. In addition to that, there was one nurse in charge. One nurse in charge is still responsible for outreaches, and without any replacement. They had not, by the time of us visiting that, they hadn't gone on leave for the last year plus, right? And see the sheer commitment. And I could go on and on because it's a really passionate story. Heroes of the healthcare system out there, but certainly it does not take away the fact that we have counties particularly have not invested in human resources, in doctors and nurses and community health volunteers and other cadres of community health in the extent to which they should. The absence of clear guidelines on the referral process. Again, I think this is it's not very clear how whether someone should come in and go straight to the county hospital. to be taken care of there, and how that, especially in referral to, for example, Linda Mama, right? That is paid for by capitation. Exactly how does that work, and do the tools really exist to be able to facilitate referral across, that spectrum? Again, there are certain gaps in that. Financing challenges. I will this a little later, but yes, I think this is something that we have to, that has been spoken about quite a lot. That we do not allocate as much resources to healthcare as we should. Inadequate formal communication and transport mechanisms. About ambulances and them, and of course stories that happen in between. Sometimes we one ambulance at the cost of 5, and then of course the usual which is such a pain to the healthcare system. Then you'd have poor relationship between referring and receiving facilities. Again, that links to my point before, lack of poor of mechanisms for emergency referrals. Again, the whole conversion with PPs and so on, inadequate capacity to monitor the system, right, and capacity gaps in data management and procurement challenges. The issue of procurement challenges, I think, is one that resonates with most of us, and I think it's also one of the main drivers to the uptake of private or the emergence of private healthcare. In terms of universal health coverage, again, I think it's important to appreciate that they have certain efforts like free maternity services at public health facilities, free or heavily subsidized rather, health insurance subsidies for the poor, vulnerable, for the poor, vulnerable, and the old, development of health financing strategy, and of course the improvements in staff and equipment. And what happens is some of this expansion of maternity weeks and so on. I mean, these are really, really good. There's good progress in this, and that progress, I think, it is properly conceived, no doubt, but definitely a lot more work still needs to be done.
Omondi, kindly, I think we are
my background. Hello?
We are losing you at some point, so if you could kindly speak to your audio and then go a bit slowly, I think we'll be able to...
Okay. Now, I think that's very well taken. So in terms of the informal settlements, the number of course, then this is the statistic that that someone alluded to earlier, where you would have a significant percentage of residents in Nairobi, 36% who basically hello.
Yes, we can hear you.
Yeah. Okay. So yeah, so 36% of the population in Nairobi, which is about about 1.5 million people in total, live in informal settlements, and of course that percentage is 24% for Mombasa. Then you would have, of course, the increase of population in informal settlements continue to exert pressure. That's that's a given. And then, of course, if you're looking at the rapid growth in population, rural to urban, is due to, of course, contributes to lack of affordable housing. Is also a result of weak governance, economic vulnerability, low wages. I mean, it's a whole conglomerate of things that actually contribute to that. And clearly we are not going to, I don't think that trajectory is going to change. Fact is, populations within urban settlements is definitely position. Literacy levels are much higher, jobs are much fewer, people move to urban urban communities in search for jobs. Agriculture is no longer as rewarding as it used to be then. So again, you're going to still have people coming into the city anyway. So it's definitely a situation we have. That's the message. Now, in terms of findings, so the findings are organized into the three objectives. In terms of the policy and administrative gaps, we'll look at very quickly the structures. We'll look at health reforms. We'll look at impact of we'll look at civic participation in health. We'll definitely look at the policy barriers. In terms of structure, I will just gloss over this. Of course, there is a sense of inadequacy of public health facilities. And that we need to then create that a correct connection between that inadequacy and the private health providers. Because when you have fewer facilities offering a limited range of healthcare services, then these facilities will most likely be crowded. These facilities, based on the issues we already around problems with availability of medicines and nurses and doctors and so on, will definitely drive the populations to seek services from players. So in Nairobi, about a total of 990 health facilities in Nairobi, and that is both that is all the health facilities. So one public, 102, driven by basically by about 109, owned by 40 private facilities. So you could look at the dominance of that. So out of 990, 640 is basically players. In Mombasa, total of 306, 55 public, faith-based, 10 NGO, 227 private sector, and this is basically data that is driven that is from the master facility list, which is a government. So there's a graph there that looks at the number of facilities in each of those slums of informal settlements surveyed. So you'd have in Kibera, for example, look at private and look at CEOs and look at NG and look at public and look at how way long that the private of the private facility really is. So that's just a visualization of the market share of health provision, if you like. Of course, as a result of this dominance, a couple of issues came up, and I think I'll probably just in terms of quotes. So in Kibera, there are several unlicensed health practitioners, and I think this is common knowledge. Medicine by unqualified individuals and sold over the counter in shops. So again, this is just from the focus group discussions we had, and at least someone even lamented that Madawa Atakwaduka. Again, basically just shows how grave this scenario is. The study also observed that conveniently the clinics are closed during inspection by the Pharmaceuticals and Poisons Board in a way that makes it obvious the private often have priority knowledge of inspection visits. Again, right? It's thorn in our flesh, instances of corruption, but it's also it is the fact that possibly those who are responsible for certain regulations are adhered to are the same ones who own those facilities, and so there's a way there's basically the left colluding with the right, and so at the end of the day you end up compromising quality of services nonetheless. And then in terms of the impact of devolution on delivery of healthcare through this, of course, as a result of devolution, there has been integration of within CIDPs, and I think, if you ask me, there has seemingly right now or over time, the county governments are act together, and it's beginning to register certain improvements if anything to go by. But of course, sorry, of course there continue to be challenges with inadequate numbers of health workers. I've spoken to that, and of course, community units. Budgetary allocations continue to rise, and the sort of like on the right on that screen, just those percentile improvement allocations. From 2013, it rose to 22%. I mean, by 22%, then it rose by 2023, it rose 25. Of course, there are still gaps in referral systems. Significant changes in case management, in increased, and of course, referral instruments, and I think I equally alluded to that. Participation, interesting. Health budget tracking is a major gap. We know, for example, in broader county budget, they say X amount of resources have been allocated to healthcare. As to what that is used for, that tracking does not happen, is not civic driven. Budget implementation reports are fairly difficult to come by. We asked for a few study, and we were not able to receive any. But I think that's just the surface issue. The more critical question to ask is, if we get X resources on healthcare, how much of that actually go to recurrent expenditure, and how much of that goes to capital? How much of that goes to clinical health, and how much of that to preventive health? Those questions are often not clear, and any public health officer I have an accountant, me included, know for a fact that there is in terms of the amount of resources allocated to private health, public health. Often public health gets a lot less prominence, yet that is where preventive health lies. That is where, that is that critical, that cost structure that, attends to people that predominantly, that live in informal settlements. And that is that cost structure that would be responsible for, frontline response during incidences like we have right now. So that definitely, I think there's an opportunity for the civil society to definitely respond to that. Then the civil society organizations focused on health, definitely, I think a lot more work needs to be done on that. And then, of course, informal settlement dwellers on how to engage the development planning process. Again, this is something that needs to be driven, like I said just before, by the private players. By the CSOs. Policy barriers, I think, slow progress, UHC, the reliance on voluntary payment has been as a contributing factor. Again, at the end of the day, when we're talking about NHIF and the UHC, the approach of the government is one and the same thing. Yet they're still able to. Yet that still is a voluntary contribution, and to the extent that is a contribution, and to the extent that a lot of those that we target, don't have expendable income, definitely they will not prioritize NHIF, and especially again with the public perception that NHIF carries, right? So there's a quote there that talks about out of those interviewed, very few, I think probably just one had an NHIF card, and even then that card wasn't valid. And of course, instances where they link, they equate NHIF, like KRA, sort of like they're just taking our resources, but we do not see quite value for it. And interestingly, they opt to, to work with MTBA because they think MTBA certainly is, is more promising than NHIF. An interesting model, though, is that the residents actually, especially in Kibera and Korogocho, this wasn't very much the case in Mombasa, is they actually are able to pay for medication in installments. So what that means is if you're given a dosage that you're supposed to take this dose, up to that point, then if they only buy a section of those that they can afford today, then they can go back, 2 days later, 3 days later, and so on. Sometimes it works, but mostly they will feel they will have possibly improved by the third, fourth day. Definitely stop going for, paying for the other installments, which they would perceive as quote unquote unnecessary. And that is an interesting scenario, but which points to a model that, some forward, there's an opportunity there to, to innovate around something like that. Two, I will, second objective, assess elements of dominance of private players in the provision of healthcare services. I've spoken to a lot of this, so I will very quickly just gloss through. In terms of physical access, I had mentioned, Nairobi, for example, just 1% of those that access public health facilities constitute only 1% accessed by residents of informal settlements in Nairobi, of which characterized by long queues, shortage of drugs, and the rest that I have mentioned. And of course, if you look at the distribution of those facilities by informal settlement, you can see the obvious dominance of that. Now, this is not the number of facilities, but this is the number of facilities visited, right? So there's a slight difference between this statistic and the one I presented on the number of facilities. So again, in a public health facilities to serve rapidly growing population precipitates the rise in private healthcare provision in the informal settlements. So again, because the facilities are few, they are unable to keep up with the demand, and of course the spillover ends up with the private players. In terms of investment in health, which is basically the cost of the cost of this. I mean, we have fewer facilities, we have fewer doctors and nurses because we are shy to invest in healthcare. At a national level, that is how it looks like. Off of total health budget, total budget versus total health budget. So, for example, you would have, we're supposed to have, we're supposed to have allocated at least 15%. Of the 15%, we allocate. That is the requirement by the Abuja Declaration. We allocate 7%. We allocated 7% in 2013, and it's basically an average of about 7%. Now, that is about half of what we should actually allocate. But nonetheless, what is even more important is that we are not just falling on that on this indicator. There's another indicator, a global indicator that requires WHO that countries allocate at least 34 US dollars, right, per capita expenditure on healthcare. Kenya 6.7. So basically, in terms of the allocation investment in health, we are doing poorly on every indicator. And of course, the reliance of NHIF remains a big problem. We have mentioned that payments, the reliance on voluntary NHIF payments, it's definitely a recipe for the slow takeoff of UH. It would be nice really to get what to further listen to Lucy's perspective. On this, but definitely there needs to be some form of reforms on how exactly that. could possibly work. In terms of, just so that I could, finalize, so conclusions and recommendations basically fall the third objective. We definitely came up with, as a result of all that, came up with 6 recommendations. One is on the community participation. So, and at this point, I will be a bit slow because I want this to sink, and I think this is the crux of the study. So, the thinking here is that there should be a well-structured, adequately funded, participatory, and people-oriented policy participation in health. Public participation has been, perceived as a box that we all just need to, governments just need to check. It is hardly meaningful. It has been reduced to a function of procedure, and its importance has not quite appreciated. Now, when developing countries and developing CIDPs and all these, national level procedures, definitely, there are, ads in the papers and ads at the community, public participation there, but participation needs to be properly guided. And that right there is the gap that civil society organizations into. Do we actually, as prepare communities to participate meaningfully, substantively into some of these processes, right? And be deliberate rather than indicate that, as that box and say there was public participation. Can interrogate the substance of that participation, and more so, of course, do we pick up their perspectives? Do we pick up their perspectives in this, right, on budgeting and how budgets are utilized? To be able to facilitate, it is definitely important that we have certain structures that can then, facilitate or enable constructive participation. And one of those is the establishment of community technical working groups, and this could definitely be very much CSO led, because certainly the government cannot check itself, and we have a responsibility to be able to do that. And maybe tied to that conversation, then to question or the role of the facility management committees. Again, there was a moratorium on facilities. I think that has been lifted, but then again, it is not clear how these facilities come into play. The provisions of the community health strategy are not in line with practice, and some of these facilities, the members have stayed for too long, never been active. They do not even understand them. There's quite a bit of work that remains to be done around an avenue for improved community participation. And again, for what is good for the goose is definitely good for the gander. So that is important for us to engage. But it's also important at the same time for the government to be able to appreciate the role of community, to be heard, and for the opinions to be factored into planning. The second one is strengthening community health. Again, we have a national average caseload of 100 households per, one CHV covering 100 households. Again, that's a national average. But then, as it is right now, while what is desirable by WHO standards is one CHV covering 2 households. Definitely, that points to the need to hire additional community health workers. Also, need for greater investment in community by county governments. Of course, resources, consider putting them on some form of steps because they play such a critical role. They're properly equipped, trained, and equipped. They're kitted to be able to deliver those. Right now, we are talking about PPEs levels. At what point are we going to talk about equally properly kitted CHVs? And then the third, investment in routine monitoring of service outlets. So every county has a commodity security working group, and there are county and sub-county management teams. Anyone who speaks would tell you that they often that they don't have resources to conduct regular spot checks and to intensify backstopping to all health. That is the message you get over and over. Why? Because there is because there is insufficient investment, or allocation of resources directed to that, and that right there, a policy issue. It's a critical advocacy issue. The presence of new licensed health facilities providers within informal settlements risk populations needs to be taken quite into consideration. It's definitely against the Constitution and the Health Act, and most importantly, it is happening because you have people who have a responsibility to provide, equally going ahead and establishing some facilities that do not meet certain standards, right? So again, there's lots of conflict of interest within the health sector. No one wants to quite talk about loudly. So the relevant county management teams to conduct routine spot checks should be assessed, gaps identified, and solutions proposed. Then the second last one, implementation of monitoring of Kenya National Health Policy and Kenya Health Act. The message here is that we are not void of guidelines and policy frameworks and plans, whatever it is. We have documents and data. We are not devoid of data. It's a question of, do we really implement these policies and guidelines in the manner it should be? All right. And is there somebody out there monitoring which some of these policies and guidelines are actually implemented? And definitely right there is a opportunity that the civil society can coalesce around, produce account by account periodic reports on the progress making towards the implementation or the achievement of the provision of some of these policies. Inclusion of marginalized groups. Again, this we can't talk about NHIF enough times. It's meant to UHC. What happens is it provides voluntary contributions, and the reality is that we have the country has many social protection programs, and the reason we have social protection programs is because we acknowledge that there are certain people who cannot afford contribute to NHIF because they equally have a problem with putting. So at the end of the day, can we then design a response that speaks to the needs of this vulnerable segment as well. And of course, lastly, is to appreciate that a lot of work, there are counties that are doing quite well. Kakamega County has done extremely well. The Imarisha Afya Mama na Mtoto program, they have used that to significantly improve maternal child health indicators, and I think that is something that the county has picked up. Kitui County has something around improving nutrition outcomes, and that is, work with vulnerable communities this is a cash transfer program. Then they're basically saying we can improve nutrition outcomes by topping up on and it's working extremely well. I'm not saying that's what needs to be done. It's definitely something that has worked so well that West Pokot and a couple of other counties, I think, are picking. And of course, you look at the extent of investment in health infrastructure and Machakos. Those definitely have been widely documented to have made quite some progress. Of course, you can say that, but quite a lot has happened, and those need to, we need to be able to pick some of those. I am aware already is following up on the footsteps of Kakamega and coming up with Mombasa Care. The design process is ongoing, and those are definitely such useful efforts. Definitely needs to be lauded because they are exclusive actions of county governments. I think with in the context of COVID, again, the study makes an argument for increased investment in the community health workforce, strong community as a foundation for disease prevention and health promotion and reduction in burden disease. And right now, the country is talking about protocols for self-isolation. Definitely, you would have if you had a health workforce that is strong, if you had a community, that are properly trained and in the community health assistance, then definitely, one, not just in terms of penetration, but also they would be very active in, contact tracing or surveillance and, and monitoring some of the cases of self-isolation. They're very much capable of doing that because we cannot have health workers for, nurses and doctors 50 households. These are basically those who preserve those for clinical level. Then we would have lots of preventive work going on within, and particularly within informal settlements where penetration has, but then that has not been, and I think is yet to be fully exploited. So finally, the study findings reveal that of healthcare is not a reality in informal settlements. Challenges of access and affordability, and I think I've mentioned why there are, of course, those challenges. Factors have been provided by the continued absence of framework for social accountability in health, suboptimal government investment in health, weak mechanisms for the regulation of private actors in health. And so the actions proposed, which the 6 actions should be packaged into health advocacy messaging by various civil society organizations or movements. Thank you very much.
Thank you so much, Omondi Otieno, for that very elaborate presentation. And I know most of us have questions. I can see some of them are already coming in. Even though we were not able to really, you were breaking at some point, but I'm sure participants were able to follow through even in the slides that you had. But I'm also sure that you are able to follow the conversation. And I would urge, if you want to ask a question live, kindly just raise up your hand and then we'll be able to see you and give you that opportunity. Now, Omondi, you talked about a lot of things in that report, some very shocking findings, to say the least. Like one of them that really caught my attention was where a resident was saying that they can even buy medicine in the shop. I mean, in the US, if you want to access medication, you have to have a prescription. You have to actually go to a doctor to get a prescription. So what this means is that there are a lot of several unlicensed healthcare practitioners, some of whom are not qualified, and I think this needs to be looked into. Now, some of the recommendations you provided really speak profoundly. And one of them is civic participation, especially in health governance, and already starting to ask questions about how informal settlement dwellers can actively and meaningfully participate in the health budget tracking processes, because it's not enough to just have allocation to health, but then, as Pauline rightly mentioned in the beginning, there's still a lot of corruption taking place. So then the question would be, what is the role of the civic population and the role of people in these communities that they can play to make sure that the health funding, the funding that goes to health, every coin is put into good use. And I want to put Mama Kenya on the spot here to talk a little bit about one of the recommendations that mentions community participation in healthcare. So I would like to welcome Mama Kenya. Please say your thoughts, share some of your initial thoughts on this recommendation.
Thank you very much, Brian. I'm so glad about the report that Haki Jamii has produced. In fact, it has brought me home because this is the reality that we normally see. I know when some people get these reports, they think that they're fictitious and just made from somewhere, but on a reality, this is what is exactly happening, especially in our urban informal settlements. When we talk about the participation of community, I think this is key because the sovereignty of this country belongs to the people of Kenya. That is in the constitution, isn't it? And this is where we need to look into and follow. If you look at issues of the budget, and this is where it touches me so much, also being a member of the CBF of the Nairobi County, it is very difficult to understand what amount of money goes to what. There's that confusion and it is there. And I'm very glad because this came out very clearly in the report. When we come to the issues of the treatment that the people get even in the health facilities, especially the county health facilities, you'll find that mostly we get clinicians are there to treat us. And some people need specialized treatment, which is not really readily available. So you'll find that without our participation as the community to shout out and say that, of course, we are seeing gaps in the communicable diseases and non-communicable diseases. How do we need to go about this? Then they will not come to a conclusion into getting the good healthcare. As much as we want to launch and to run this program around the county, there are so many things that are still wanting even right now. The biggest confusion now on the issue of health in the Nairobi City County, especially, whereby we know that health was devolved to the county. Now we have the NMS. Again, health has gone back to the ministry. So you see, there's that confusion yet. And still, we'll still need the public to participate in such issues. Because if we do not participate, then automatically, we'll still have that gap. And most of our people in the informal settlements will be suffering because they won't get the treatments and healthcare that is quality. Mostly when you hear people in Nairobi saying that we can buy drugs, of course you can buy drugs anywhere without a prescription in Nairobi. It's so easy to access all these drugs because there's some laxity somewhere. So if we do not participate and come out clearly to get involved and even do public awareness to the communities, especially in the urban informal settlements, on how they need to engage, then automatically the policymakers will be making these policies that flop every now and then. Most of these things should not only be policies, they should be enacted. Let them be enacted and let them be on paper and let the implementation be done in the right way. Because we've normally seen Kenya is a very beautiful country where we have so many policies and implementations that have been done. But when you follow up, do they really implement what they say? Do they preach water and give us wine? So we need to be very key on the issue of public participation, especially in our urban informal settlements. And we need to talk to the people and make them understand that getting healthcare and quality healthcare is not a favor, but it is our right, prescribed in Article 43 in the Constitution of Kenya. This is the only way that we need to come in and work. There's another part of the healthcare that has been cut off when we come to the community health workers. These are people who are exposed to getting even infections. They are involved in even spending a lot of their time. Rather than looking for their daily bread for their children, they run into households to go and see what these people are doing. But when we come to the reality, after doing this hardware work, and then they take it to those people who are going to do the software work, what do they get in return? So we need also to have a lot of advocacy in ensuring that the community health workers are being taken care of, are being given their rights, and even are being facilitated. Because we've seen a lot of funding come in. Apart from what has been budgeted from the government, especially in the health sector, we have a lot of donors who come in and give a lot of funds. But are we really clear on what these funds do? Why don't these funds be monitored? And as Pauline rightfully said, corruption has taken a lot in our country. And I also agree, because we are really corrupt. And let me start with myself. If we could put all these things in line, then even the community health workers could be facilitated in the right way. And we would see our health systems getting improved. When we talk about our facilities, and especially the government facilities, most of the times you'll find that they lack a lot of commodities. They lack the right items to do tests. They sometimes lack drugs, so they'll give you a prescription. At the end of the day, where will you go? You'll still go to the pharmacy or the private facilities. And remember, when we're talking about private facilities, these are people's businesses, isn't it? And when you're talking about people's businesses, it becomes very difficult to control people's businesses. So even if you are under the cover of the universal health, even if I'm under the cover of the universal health, automatically, when I go to the private facility, I'll be subject to their mercy. And still, I will not be getting the correct health care that I expect. So with me, I've come here with one voice that it is time we wake up, the civil society, the community, to advocate for the right health care. So that when the universal health care starts rolling even in Nairobi, at least we'll be sure that about 25% of our informal settlement people will get the best healthcare. I know Rome was not built in a day. It's not very easy to make things work 100%, but we should at least come to 65 to 70%. I don't see why, after independence, all this long time, we still have a very big gap on healthcare. And yet, we say that the people are the ones who make a country. And if we are sick, then the country will not move on. So I think when we talk about this report, I really appreciate what Hakijami has done. And the recommendations that you have come up with are very key. But also there are also other elements that we need to look into. Like, for example, the health providers, when they're employed, do they really get enough? You know, in Kenya is a very funny country, and I'm sorry to say this as a human rights defender. A policymaker will get a salary 5 times what a healthcare provider will get. And we look at it and say it's okay. But can you imagine the risk this healthcare provider is getting? Can you imagine that this is the person who meets more than 100 people per day? And yet the policymaker gets more money, but then the healthcare provider is low in salary. We need also to look at how the standards of payment for our doctors, our nurses, even the people who work here, even the casual laborers in the facilities, so that once they are comfortable, then I'm sure even corruption will go down. Because as a clinician, I would not want to sit here the whole day doing work that will not even help me. And with the economic status of this country, I will have to do some other things. And this is when we condone corruption to continue in our country. So the best thing, let's also, when as much as we're implementing and looking at the recommendations that have come up in this report, let's also add some few things that need to be added, like looking into now the seriousness of even ensuring that the labor of these people is also looked at, so that we can get the right treatment. When you come to communicable diseases, most of the communicable diseases have a lot of gaps when it comes to healthcare in Kenya, and especially in our informal settlements. And you know, these are the people who are more prone to non-communicable diseases and communicable diseases again, because there is lack of sanitation, lack of water, so communicable diseases are many. When we come to the lifestyle, poverty, and what else, you'll get the communicable diseases are there. And non-communicable diseases like high blood pressure because of stress and the rest are still there in the informal settlements. So we need to strengthen and ensure that even in our informal settlements, let us have government facilities whereby everybody can access the universal health care free, without stress and without interruptions. I think that's my take for now.
Thank you so much, Betty. I think you've rightly said, you've mentioned a lot of very important points. And one of the things that you said is getting healthcare is not a favor. It's actually a right to everyone. And this is also articulated in Article 43, as she also mentioned. But she has also gone ahead to say that public awareness, people are not aware in these communities, especially in the communities that we work with in the informal settlements. They are not aware that health is their right. And so the first step, as Mama Kenya has proposed, is to start with public awareness to the communities on how to engage, to know, like, this is the budget that has been allocated for health. So how do we ensure that every coin is put to good use? And another point was on enacting of policies. We have a lot of good policies, but now the problem comes when it comes to implementation. Now, I want to move forward to the next panelist, who is Lucy Nyambura, who is also from the county government, and I think she'll be able to give her perspective from the county. And we are in this group, the PHM, the People's Health Movement WhatsApp group, where I'm glad a lot of conversations have been going on, and especially in terms of UHC, like, what do we need to do? And I want to quote one of the members in yesterday's conversation, talking about how COVID-19 has already poked some holes in the UHC in terms of how it's supposed to be rolled out. So the question, therefore, would be for you, Lucy, are there any alternatives for implementation of a more robust, people-centered system of healthcare delivery, and especially making reference to some of the findings and recommendations from this report?
Thank you so much, Omala. Allow me to start from Omondi's presentation in terms of, let me start with the budgets. I cannot comment about Nairobi, but I can comment more on Mombasa, because that is where I am, and I'm a CTMT member. So I'm one of the people who prepare the budget for health. So our county, as Mombasa, gives us about, let me start with from 2018. In 2018, Mombasa County's budget, the whole budget was 12.5 billion. And Mombasa County gave us 2.5 billion, which is about 20.7% of the total budget. In 2019-2020, the total budget for Mombasa County was 13.5 billion, and Mombasa County gave the Department of Health 3.04 billion. Now, the one thing that I know for sure has been a challenge is that in Mombasa County, our biggest challenge has been our workforce. The amount of money we spend paying our workers is much, much more, such that it leaves very little money to do our recurrent plus our development activities. And I think because of that, that's the reason why we have so many of the challenges that we have as health in this county. Number two, I've heard of the community health volunteers requesting to be given a stipend. I believe that is a discussion that is going on at the moment, but it is going to be a bit of a tussle with the counties. Reason being that, let me give an example of Mombasa right now. We have 1,500 community health volunteers. And at the moment, as we are speaking now, there's a recruitment going on of more than 1,290 community health volunteers, meaning that we are going to form 129 community health units. Now, Now, having a workforce of only community health workers coming to almost 3,000, trust me, it might not be easy for any county whatsoever to support them by probably giving them a salary or a stipend or even the insurance as everybody is asking for. However, we can look at it in a different way. If suppose today the county decides that they cannot afford to do it, then let us do it in a different way that can be able to support the CHV. I'll use the example. I'll use one of this. I formed 2 CUs during my time when I was in the sub counties, and one of the methods that I used at that time was that any partner who came to support any activity in health that needed to use our community health volunteers, we signed an MOU together, just as a CU, not as the county, but as a CU. So like I would take my community health unit, mine was called Bangladesh Community Health Unit. And I would sign an MOU with the partner so that the money goes into the kitty of the CU, not an individual at that particular time. So what happens is, once the work has been done, you give the person who did the work 90% of the money and you retain 10% in the account. So as we were going on like that, at one point we found ourselves with over 800,000 of the 10% that was remaining, and the 90 was being given to them. So what does this mean? It means then that every week the community health volunteers had some money. So when they are not going to do their business, at least they have some support coming to them every week that they are able to. And by the way, at the end of the month, they would end up with almost 8,000 to 10,000 shillings. But at least they're able to also do their own businesses, which we are also encouraging them to have. Yeah. So during that time, so with the 800, it was supposed now to cater for those community health volunteers that did not get any support during the month. So then we have an activity like now the dialogue day, the cleanup or something too, that will be able to allow them now to utilize the 800 that we had saved in our account. That way, all the community health volunteers were able to have some form of income at the end of the month or every week. It all depends on how we organize ourselves. And trust me, our community unit did very well, and it was among the best. Now, if we decide, for example, that we encourage the government to give the stipend, I can guarantee you that the stipend will not be more than 4,000, for example. And if it's not more than 4,000, then what does it mean? It means that all the partners that come to every county to do any work with the community health volunteer will have to put all their money into that kitty so that at the end of the month, their CHVs are given the pocket. Yet, if they come to the county right now and they take the CHV and work with them, a CHV within 5 days might be able to get even the 4,000, okay? So it is easy for us to keep on pushing for them to be given the stipend, but at the long run, it might not be as good as we think it should be. But I'm not saying it's not a discussion that should continue. I'm only saying that let us also think about other avenues of supporting a CHV. Another thing is that who will be managing the CHVs? Initially, it has always been the public health officer and a nurse. So the public health officer is called the field chief, and the nurse is called a facility chief, meaning that when the CHV identifies a patient with a condition, the first person to be called is the PHO, the public health officer, who then supports the CHV to refer the patient to the nurse in the facility where the referral is filed. So anybody who wants to follow up on whether the CHV is working or not will be able to see the referrals. Unfortunately, what has been going on today is that most of non-government organizations have been supporting only the CHVs and forgetting the CHUs. So you find a CHV with a lot of information on a particular disease, and the CHU who is supposed to be supervising that CHV does not have any information or has only information that is not current, like what they learned in college or something, or just ended up reading something in the internet and something like that, which is not right. So I think we also need to reorganize ourselves and support the CHUs before we go train the CHVs so that they can be able to support now the health system. Something that is also going on right now, which I also feel like is going to really distort the community health, is that they are now recruiting people called CHAS, community health assistants. These people will only deal with community health strategy. This is not right, because if you look at the public health officer is trained on 45 different things so that when they go and when they go to the community, they do not only address what they are going to see, they address so many other things. And so when you have this public health officer addressing so many other issues, it becomes easier and better than having an additional person who will only address one particular thing. So having another set of community health assistant does not really support improving the health system. It is only now the continuous, we are kind of breaking down whatever good system we had put in place. My suggestion would be, instead of forming another community health assistant, let us bring in more public health officers who can manage the CUs and also manage all these other, the same people you want to go and train as CHAs, train them as public health officers. Use that fund to train them as public health officers. And also bring in the nurses, because they're the ones in the facility. Train those ones to be nurses, so that we have the nurse at the facility and the public health at the community. But having another structure that is going to destroy what we have worked so hard for up to where we are right now. Now that I'm done with the community, in terms of finances, allow me to say that universal health coverage is not as bad as you may think. Actually, it all started with transforming health system for universal health project. This is what is supported by World Bank. So what World Bank did, World Bank supported, took 6 counties to be pilot counties to do the THS. It's called THS, Transforming Health System for Universal Care Coverage. So what they do, these counties were given a lot of money, let's say 100 million, to do everything for the residents of those 6 counties and give them everything. So they go to hospital, they don't pay anything. And then the rest of the other counties, which Mombasa is one of the rest of the other counties, we've selected 4 indicators that are so important to health. And one of them is family planning. We have the 4th ANC visit, and then we have the fully immunized child. And then we also have inspection of the clinics. And I think there are 5, I have forgotten the 4th one. So what happens is, for us to be able to access more funds from the THS, we need to improve these 5 indicators so that we reach the level that they want. Now we have targets. So these targets, if we improve on these targets, the more funding we get. So our uphill task was to make sure that every mother who comes to a facility, a pregnant mother, takes the 4 ANC. So we work so hard to ensure they get the 4 ANC visits. We make sure that the child is fully immunized up to before they reach 1 year. We make sure that all the people who come for family planning get the commodity, that whatever the service they need, yeah, something like that. So what I would say is, in terms of funding, if we can be able to go the THS way and do it in the UHC, I believe we'll be able to succeed. And let me tell you something else. UHC has already started kidogo kidogo. What they've done, they've allowed us to get funding, to get drugs from KEMSA through pull and not push. We decide what we need, we request for it, and then we are given the drugs. So right now we are on quarter 2. So the first quarter has already, actually for Mombasa, we delayed a bit because of some signing that was supposed to be done. But now we're on track, and we are soon going to get our drugs. And very soon you're going to get all the facilities getting their drugs. Once we are done with that, we have said, they've already started. Now the second portion is where I talked of the community health volunteers increasing the number of CHV. Right now, as I said, there's 129 CUs being formed, and they're supposed to be done up to end of this month. So already that process is going on. And there are so many. And then there's something called Danida Funds. Danida Funds are funds that are given by Danish to support all our public health facilities, the dispensaries and the health centers. And Mombasa County last year received 13 million, and actually it's 26 million. So every facility in Kenya receives this Danida. Most of the facilities in Kenya receive this Danida funds. So they are also supporting these facilities. Now let me go to the private vis-a-vis the public. We talked of, there are many private vis-a-vis public. You see, for us, we look at it in a bit different way. What we say is, you have at least one facility for every 5 kilometers, so that anybody can be able to access that facility. either by transport or by walking or by whichever means, but at least they're able to access those facilities. What I would suggest is that instead of you thinking that we should add more facilities, let us increase the time the facilities operate. Instead of operating for only 12 hours, let us increase it to 24 hours. Because if you go to most of our public health facilities, you realize that in the morning, there's just so many people. But you go in the afternoon, there is nobody there. The facilities are empty. So the staff sit up to saa kumi na moja and go home because they are not clients. Meaning that most of our people come to facilities in the morning and they don't come in the afternoon. But you're also saying, let us also spread let us tell our people that in the afternoon, the health workers are there and they are working. They should continue going to the facility. And where possible, let us have also locum for our health care workers so that we have night duties so that they come. Mama Kenya, I can't remember the name, talked of the going to a facility and not getting all the services they need. Let us also appreciate that all our facilities have different tiers. We have the dispensaries, which can only offer a certain level of healthcare. We have the health centers, which also offer different levels of care. We have the referral facility, which offer different levels of healthcare. So when you understand that bit, you will be able to know when you go to that facility that you will be referred. So what do? If you want to know the kind of care that is provided in that facility, every facility, government facility, has something called a service charter. If you look on the wall or the signboard, it shows you the type of facility, the type of services that are offered there. So once everybody understands that you cannot get all the services in a dispensary or all the services in a particular level, then it will be easy for them to know that they don't need to really expect much there. They expect probably the primary healthcare services that are provided at that level. Another thing about, let me also look at the private facilities. I know that, yes?
Running out of time.
Okay, let me just talk about the private facilities and then I'm done. So for private facilities, we conduct something we call support supervision. Even though they know that we are coming, it is not a bad thing. A long time ago, we used to call them, we used to fault finding kind of support supervision. Now we are doing facilitative supervision, meaning that we can actually call them and tell them we are coming. Why? Because if you do it secretly and then they run away or they don't show you everything they have, then you'll never be able to help them improve. Our interest is not to fight them or to close them down. Our interest is to improve them. So you call them and tell them we are coming to a facility, kindly wait for us. So when you go there, whenever you see anything that is not right, you rectify it there because they have a book which we usually conduct and then we write what we have seen and what we've recommended them to do. So today, the world is no longer about fault finding, it is about facilitating a session. So we are encouraging the private facilities to operate, but not in fear, but to operate in a way that we can be able to support them to make sure that they provide good service. Now, why are people going to private and not public? There are three reasons. One is because our facilities are overwhelmed and we cannot build more facilities if they are near each other. So we are encouraging the private because we even support some of them, like the faith-based, to give them commodities to support us with our work. Number two, people go to private because some people it's prestige. It's prestigious to be seen to be going to a private facility than going to a public facility. Most of us here go to private facility out of prestige. If you are told to go to a government facility, some of you will not even want. Number three, some people come to hospital at night because of their work, and most of our facilities are closed. So what do you expect? The private facility will get work because of our facility being closed at that time. That's why I'm saying we can encourage our facilities to at least continue opening at night. And how do we do that? You as NGOs or a civic organization can support our healthcare workers by, like we have a memorandum of understanding where you say, we as Haki Jamii can be able to support 2 health workers in that facility by giving them a stipend every month. So you bring them to our facility, we sign an MOU and we agree, and they support that facility. That is the best way of doing it. Number 2, we have the committees in the facility. We cannot, I know Mondis has suggested that we bring in the technical, I think he called it a technical working group or technical committee that within the community. I would suggest that we still have the facility committees, but now what we need to do is that we as a civil community organization, we need to go to those facilities and attend some of their meetings, because we are allowed to go there as CME, you know, they're called CME. You just request that I would like to come and sit with you during your CME so that I can also give my input, because every facility develops their annual work plan. It is that annual work plan from the facility that goes to the sub-county and then to the county where I sit, and then we consolidate what has come from the facility all the way to the county. So it is very easy to engage our facilities. It's only that most times we want to be called. Sometimes it's not about calling, it's about you coming out and taking yourself to the facility and saying, I would want to participate in the development of the AWP. And you don't have to really sit there and develop, but you can give your input so that when they are putting up they're doing their AWP, then they have your input there. And use the committee. The committees are not there permanently. In Mombasa, every, I think 3 years, you get a new committee. Unless they perform very well, then the committee, they were 90 requests that let us keep them for another set of probably 3 years for them to continue. And we've seen a lot of progress because of these committees, because they're also the resource mobilizers. I believe I've given enough, and any questions coming my way, I'm here to answer them. Thank you.
Thank you, Lucy. I think there are a lot of questions that are being directed to you, and I'm not sure if time will permit for us to be able to go through all those questions. I agree with some of your points, but I respectfully also beg to disagree with some. I know you've mentioned some of the reasons why people seek for healthcare services in private health facilities, but the truth be said, there are a lot of inefficiencies in public healthcare, and we need to think about, when we talk about solutions that we can potentially implement, they need to be sustainable. You know, we need to think about long-term solutions that are sustainable. And another thing is, you know, you go to a health, I was in Mama Lucy Hospital sometimes in February, March. They didn't even have a thermometer, you know? So that tells you, if you cannot afford a thermometer as a public healthcare facility, what makes me think that you have a refrigerator even to put vaccination medicine there, you know? So there's a lot of inefficiencies that we need to acknowledge first before we can talk about solutions towards those problems. But I really would like us, I know we are running out of time, but I want us to give opportunity also to our panelists. I know you're there, Betty, if you can hear me. I know that for this 2020-2021 budget allocation, 111.7 billion was actually allocated to health, and specifically 50.3 billion to UHC. And, you know, now, due to the advent of COVID-19, a lot of these resources we've seen are being redirected to address the effects of the pandemic. And so the effect of this is that women's needs have been largely overlooked. And, you know, as you know, SRH, women, even at this time during the pandemic, the truth is, you know, people are still having sex, people are getting pregnant, so they need to access these services at the healthcare facility. Now, if you redirect all or majority of the resources to address the effects of COVID-19, it means that some of these needs have been overlooked. So, you know, Betty, I want you to talk a little bit about this, and also just try to make reference to this report and mention some of the initial remedies to this situation.
Thank you, Brian. Hello, everybody. My name is Betty. Brian, first of all, I would like to appreciate Hakijami for coming up with this report during this time, especially this time of epidemic. The study has revealed the inequality that is there in Kenya between the haves and the have-nots. It has also revealed that the government has failed its fundamental duty of respecting and protecting and promoting the fulfillment of the rights to the highest attainable standard of health. That includes reproductive health care, that include reproductive health care and emergency medical treatment. If you look at the report, it shows that at the
Betty, your audio.
settlement.
Hi,
That
Betty.
is where we get the level 1 of the health facilities. That is where you get the dispensary. But when you estate, that is where you will get the level 6. Hi?
Hi, Betty. Something to get you very clearly.
Hi? Are you getting me now? Oh, shit.
Not yet.
Hi.
Betty?
Hi. I am getting you. Are you getting me?
Yeah, I think we can get you now.
Are you getting me now?
Yes.
Yeah, I will not be able to use my video because of the internet. If I'm using, you may not be able to get me clearly.
Okay, that's okay.
What I was saying is that
Lost. All right. I think we lost Betty. Now I'll just like us to go through some of the questions, even as we wait.
The study has revealed it's a fundamental duty of the promoting the fulfillment standard of health. That is.
She's mute. Okay.
Again.
Okay, I think we have lost Betty. I think she has a very strong internet connection. But Betty.
Hello?
Hello, Betty?
The internet is. The internet is.
Yeah, I think we might have to let you use the chat box to respond to some of the questions that have been asked. I think due to the interest of time, we are running out of time. But if I scroll up, I can see that some of the questions, especially from Maureen Mwadime, and this is, I think, has been directed to Omondi. She's from Kenya National Commission on Human Rights. Number 1, health is a shared function between the national and county governments. Has the 7% average budgetary allocation for years 2013 to 2017 also taken into consideration the county budget allocations? Number 2, kindly clarify on the section of the report that indicates that the county governments are under no obligation to procure from KEMSA. A statement by the COG released in May this year cited inflexible government procurement procedures and monopoly by KEMSA as an obstacle in effectively combating COVID-19, and urged the MOH and Parliament to review or suspend the law to allow county governments to procure from other suppliers. Are the procurement restrictions only operative during this pandemic? I think Omondi will respond to that, and then Grace Solo had raised her hand, so after that I'll give her the opportunity to directly ask her question. Omondi, maybe you can give your thought, and then we can have Lucy, and then I'll give Grace opportunity to ask.
Well, so the study really wasn't. So it's useful to point out that I'll probably be responding to this purely based on my knowledge of the sector. And not within the context of the study, because the study did not exactly, look into at depth on it wasn't a deep dive on procurement, neither was it a deep dive on health financing. But sort of like, we understanding that those were contextual issues, we definitely needed to, tease out some of those that might have an effect on, on service delivery within informal settlements. So yes, so we did touch on that. Now, KEMSA and procurement. The law the policy has been very clear that the primary provider of, pharmaceuticals and non-pharmaceuticals, the primary provider would be KEMSA for all counties. And I think it was reasonable to do that for the longest time. And largely, it was because government needs to be able to regulate the quality of drugs that are available. I mean, of course, the list of essential medicines is definitely out there. It could equally be procured anywhere else, but the government, of course, needed to ensure that there is some form of it's easier to regulate. Now, that was the provision, but there was also another provision that for drugs that or products that KEMSA does not have, you can, counties can seek alternative suppliers, and this could be, the Catholic Medical Missions Board. This could be meds. This could be, any other major providers. Then there was a third line where, you could procure locally. So it was meant to work very smoothly, but I think to a large extent that has been the cause of delays in supplies of drug consignments. There have been, because of the monopoly enjoyed by KEMSA, in many instances, they have come out and either, stuck their grounds and said, listen, we are not supplying county governments until our payments come through. And then the county governments are left with very little choice. It also meant that they had to stretch their capacity really wide and thin to cover the entire country. And I think somewhere in between, they worked on establishing regional warehouses. So there has been a lot that is going on just to ensure that, KEMSA basically pulls their weight in terms of supplies of pharmaceuticals and non-pharms. Now, of course, under the circumstances of COVID and the need for speed in procurement, there have been waivers. And I remember, the PS or the cabinet secretary actually pronouncing themselves on that. I cannot speak to whether it will last beyond the pandemic. But what I know is that it has been a thorn in the flesh of procurement systems for drugs in this country. And if it was up to me, I would highly recommend an adjustment to that. So that's on the procurement restrictions. On the The 7% is basically a national level allocation, and county governments have their own their own percentages. I think we just listened to Lucy not so long ago talk about Mombasa County allocating up to 22%. Some counties, 21%, 14%. Every county has different level of allocation of budgets on healthcare as a share of the total of the total budget. I mean, nonetheless, I think sometimes when we talk about figures like 22%, the question is, does it meet at the bare minimum threshold? Yes, it does meet the threshold of 15%, but 15% was at a country level and should also be looked at as a share of the of GDP. So yeah, I guess that answers the question. That 7% was definitely at a national level and did not fully take into account allocations at the county level.
Thanks, Omondi. I think I'll give this opportunity to first Grace Olo, and then second Christine Ajulu, and then lastly David Juma. Kindly take maximum 1 minute to ask your question, and we'll have them answered. So Grace Olo, kindly go ahead. Grace, are you with us? If not, Christine, are you there? Christine Ajulu? David Juma? David, are you there? Okay.
Hello. Hello.
Yes, David.
Hello. Yeah, Brian.
Yes.
Oh, that's Grace.
Yeah.
Okay, Grace, you can go first, and then we'll have David next. Grace? Amepotea. Either Grace or David.
Hello.
Yes.
Can you hear me? Can you hear me?
Yes, I can hear you.
Yes, one of the findings in the report that there is no clarity where especially in the financing sector. And one of the things that I wanted to ask Lucy, unfortunately that Lucy has gone, when you go to the budgeting process of the health department, for instance, in the Mombasa County, they continue talking about, like right now, if you look at the 2020 and 2021 budget, it's about nearly 92.2% is given to the personnel. But there's no clarity who is this personnel that is being paid with this money, because there's also been a case of complaint that is shortage of human resource. Then secondly, we have a program, mostly the budgeting process, our program is mostly they're not program based, because if we have a program based budget, it will enable us, even the informal people, to understand how the budgeting is undertaken. For instance, today, if you compare the budget for 2020 from Baringo County and from Mombasa County, for Baringo County is very clear in terms of projects, sub-projects, in terms of indicators and the finances that have been allocated to those projects. So I think this is something that we also will add counties, that whenever they're doing that, their projects, their programs, their budgets are supposed to be program-based, which are with a lot of clarity. Again, to Lucy, she had left. When I went through the Mombasa County budget for 2020, there was no allocation. And I think we did a petition to that as a network that was trying to talk about on the COVID-19. And we thought this is a pandemic which had an emergency and we were supposed to focus on it. However much it allocated 3.6 billion to the health sector, but nearly 92.2% goes to the personnel, which there is no clarity who are these personnel. At the same time, they're saying they have a shortage of human resource. In the report, I wish there could be a recommendation on when it comes to governance and administrative, that it could be easy if there was an establishment of an independent health commission that could do placement like the Teacher Service Commission does, so that we don't find inequalities in terms of human resource at the county levels. Because when it comes to application, sometimes I'll apply as a health worker, I'll apply in a county which I think is favorable for me. And this is sometimes find that some counties have an inequality when it comes to human resource because of their maybe geographical allocation. So I'll request maybe we would have come up with something like that for an independent health commission that will do this. And finally, I'd also suggest that if it is possible, we could recommend to the government to have a serious human resource audit in the health department so that we know what is the skills gap that we have and what is the needs base as per county when it comes to human resource. Thank you.
Thank you so much, Grace. David, are you still with us?
Yeah, I'm with you.
Okay, kindly go ahead and ask.
Yeah, I'm David Juma, working for National Gender and Equality Commission. Yeah, our office is based in Malindi, but our operation we does in 6 coastal counties from Mombasa to Lamu. And our mandate largely is to advocate to promote gender equality and the freedom from discrimination. I wanted maybe to ask Mr. Omondi if the report has tackled any category of PWDs that are finding very hard time to access facilities in the country. Is that report has anything to do with the PWDs or the elder member of the society, like those guys over 70 years? Do you have in that report? Do you have any segment that has captured their plights? And then a question I want to ask Lucy, but I think has left it, where he said that most people prefer private over the public facilities, and the reason is most of these public hospitals, most of those who run those public hospitals, they have their clinics, and those clinics, when you go to the public hospital and you see that there's no medicine there, that medicine has been taken to the private hospital, and when you go there, you'll be recommended to go and buy to somebody who is working in the public sector. Can you have maybe a law that you cannot operate a clinic when you are still serving the public health? Because most of these healthcare, those privates, they are working in public while running at the same time running a clinic. And when you go to the hospital, you will be told those medicines are not here, but government has applied those medicines in that public hospitals, but they're not there. These guys have taken all those essential medicines, leaving out only paracetamol. When you go to the public hospital, you'll only get paracetamol. But apart from paracetamol, they will take you to go and buy in their own private sectors. So I'm very happy to at least you have raised this discussion, and the Haki Jamii at least will be linking up time to time, because you are doing the same things, promoting the marginalized, while as a commission, we have 6 categories: children, women, persons with disabilities, marginalized and minorities, youths, and elderly. So these are a good thing, and we are doing the same thing of promoting the gender equality of everybody. So maybe Omondi, I need to see your full report so that I can verify and maybe I can comment, because I haven't seen the whole reports. Thank you very much.
Thank you, David. I would share my email at the end of this call. So if you wish to have the copy of the report, kindly share with me your email. You can also as well start typing your email addresses so we can take note of those and share with you. Now, Omondi, even as you prepare your response to some of the questions raised, I would like to give this opportunity to Betty. I hope you're back with us. You can maybe react on the report and as well as some of the questions that were raised. I know Lucy left. It would have been good if she could tackle some of those as left. So maybe you can probably react to some of those questions. Betty, if you're here with us.
Thank you, Brian. I hope now I am laudable.
Not really. Not
Hello?
really. Betty, we are having a little bit of trouble hearing you.
Am I audible now?
No, no, not really. Well, I think we intend to finish in 10 minutes. So I think it would be best for you to just type in your response at the chat box. Is that for you?
Let me try a device.
Okay, okay. Okay, so Mondi, I think you go next. Try to, please take, is it 2 minutes to respond?
I think I will take, please request Betty to mute her microphone. There's some noise. Okay, good, that's better. Now, very quick ones in terms of, I will sit in for Lucy, though I cannot speak for the county government of Mombasa. In terms of the budget, I think it fills me with so much joy that, you know, Grace is raising such questions that civil society, the civil community already is beginning to ask those questions, because those are the questions we really need to ask. You have an allocation of 3.x billion Kenya shillings towards health. What exactly is it going to do? And beyond the allocation, are we then able to get an expenditure report in the subsequent year? Can we interrogate exactly, you know, this is what was allocated and this is how much was actually absorbed? Because, I mean, shock on you. You'd be shocked to actually realize that of that 3-point-something billion, much as it's inadequate as it is, they still have to sometimes, you know, send some of that money back because the system has not been able to absorb it. And that is largely because of inefficiencies within the system. As a civil society community, we must be constantly interrogate those questions. And just like I mentioned within the presentation, when you have 3.2 billion and you have 92% of that allocation going into recurrent expenditure, what are you leaving for the expansion of health facilities? Populations grow year upon year. What are you doing? What are you leaving for the expansion of facilities? What are you leaving for the hiring of additional staff because either due to natural attrition? What are you doing? You know, what are you allocating to private? I mean, to primary healthcare, to the community health strategy, to the CHVs and everything else? Are you leaving everything else to appropriations in aid? So then there's that whole, you know, questions that I think the civil society, I don't have the answers for you, unfortunately, Grace, but I think you're definitely in the right direction and you need to continue to ask those questions. HR audits have been conducted. It is not that these county governments are not exactly aware of what the skill gaps are. I mean, there are studies supported by USAID and FHI and all these other agencies that have actually supported county governments to establish, you know, skill gaps and so on. It's a question of whether recommendations from those reports are getting implemented, and whether civil society organizations, platforms like PHM and the one you work for have access to some of these reports, so you can use them to engage the county government. But the audits are there. It's just a question of whether there's follow-up. PWDs, this was coming in from yeah, I think so the question from Kilifi, the question on the involvement of PWDs, basically the study focused on informal settlements, and in the process of the study, there was a deliberate effort to capture the perspectives of women, of youth, of you know, of course, men and people living with disabilities as part of the whole, and not necessarily give any special focus to any demography. So yes, their perspectives were definitely sought, and the study was very deliberate in ensuring that their voices were captured. Private versus public, I think this is a policy issue. It is in the civil. It's in in public service through and through, where you have people in government working for the Ministry of Roads, constructing, equally having construction companies, the same way you have doctors and nurses running health facilities. This is a serious, a policy issue which I think needs to be tackled head on. And I think it's about time that we organize ourselves, as we created civic space for such conversions to happen, and we need to continue definitely putting pressure for such clarities. I mean, such ambiguities to be clarified. I think I addressed all of them.
Thank you. I'll invite again. Let's try one more time. If Betty can be able to talk through Tom's device, let's try one more time if she's able to. Betty, can you hear us?
Naingia.
Okay, okay.
Yeah, that's good.
Hello?
Betty?
Hello?
Yes, Betty, we can hear you.
Hello? Can you get me?
Yes, Betty.
Thank you. I am sorry for the failure of the technology. What I'll say now, because time has gone, I'll talk about the access to services. When we have only one doctor against 2,000 patients, that gives opportunity for the quacks to take advantage for the people living in the informal settlement. And that is where now you get high data of maternal mortality. And also, when we talk about access to reproductive health services, high data of unsafe abortion. You find that in such cases, at the informal settlement is where you get the level 1 health facility, and at the estates, that is where you get the level 6. Women are not in first and foremost is that their income, they are disadvantaged and they have low income, and now even getting the ambulance to go to the referral institution becomes a problem. And it is so sad that is we are living in a country where we have the first lady that have a program of campaign on beyond zero campaign, where we have every year annual we have collection, and the women are going to run so that they should again die when they are giving life, but they keep on dying. And now that we are in an epidemic, the reproductive health services has not been mentioned in the essential package, and no one is talking about it. Even the first lady who has the campaign on beyond zero, women are dying during curfew when they are giving life, and no one talking about it, even though the CJ is talking about increased number of sexual violence, but no one is caring whether the survivors are being infected, the number of STDs, the number of unwanted pregnancies. No one is talking about them. In this policy, we should also, it should also come in on, we should also factor in during epidemics, we need that the reproductive health care be one of the essential cares. And I am not in support of Lucy when she talks that we have many health many community health volunteers that cannot be paid. No, the money that is going to corruption is more than what can be paid to community health workers. No one is ready to do unpaid work. Already they are volunteering. What they are doing is so much. And now that the ministry is talking about taking the patients of COVID-19 back home, who is going to take care of them? The community health workers are, because these are the people who are in direct contact with the community. The community will be calling them and they will be doing unpaid work. These people should be having health insurance. These people should be getting their stipend. What they are looking for is just the stipend, it's not the salary. And we should factor into that. They should be motivated. And in the recommendation, Mr. Mondi talked about citizen participation. This is very key, especially at the grassroots level. The community must know what kind of development in health, in public health, is going to be funded. This is a country which signed the Abuja protocol many years ago, and yet up to today, we cannot attain the percentage of the budget according to the treaty that the country had signed. I hope I still have time.
You have 1 more minute.
Thank you, Brian. I am sorry about the technology. I am very, very sorry. But if anybody have any question to ask me, kindly just share, let them share with you and I will answer. Thank you.
Thank you so much, Betty. I think we are now moving on to the final stages of this launch. I want to also be respectful of your time. I know we were supposed to end at 1, but because the conversations are very robust, we have had to extend until 1:30. But I want us to really conclude in the next 3 to 5 minutes. Now, Christine, you are not able to ask your question, so I'll give you 30 seconds, and then I'll have Mama Kenya respond to a question by Millicent. She asks, why can't the county government pay stipends to the CHWs and yet they pay other workers? Is it because they don't appreciate the work they do? If we depend on donors for the stipends, like Lucy mentioned, then what will happen when they pull out? I'll ask Mama Kenya to respond to that as we conclude, as she also give her final remarks. But first, Christine, if you're there, you can take 30 seconds to ask your question or give out your comment.
Omala, your sound is low. You are low.
Okay. No, I just asked Christine Ajulu. I don't know if you're still with us.
Yes, I am. Can you hear me?
Yes.
Thank you. So one, I wanted to talk about the issue of budgetary allocation. I think we need to strategically move from the 15% and ask ourselves what exactly is the budget doing? And that discussion has already started. Because if we look at the county allocations, we are giving more than 30% of the budget, but 80% of that 30% is going into human resource. This brings a challenge in the delivery of services. I hope this message will get to Lucy. I wanted to respond to 2 of her concerns about service charters and persons really getting to understand the services offered at the lower cadres of health. One, the service charters were not developed in a participatory manner. These documents were from the Ministry of Health to the health facilities. The community doesn't know what the service charters are all about. They see documents there. Nobody has ever taken time to educate them on what service charters are all about. So this is a gap we've identified in various counties that we work with as HERAF. And finally, when we talk about Danida Funds, again, this goes to Lucy, the money does not get to the facilities, or there are delays which hinder service delivery. So this again should be critically looked in when we are talking about service deliveries to the communities. Because of time, I will stop there. Thank you.
Thank you. Thank you so much, Christine. Now I will like Mama Kenya to respond, and then we'll do one round of just concluding remarks for our panelists, including Mama Kenya, Omondi Otieno, and Betty Sharon, even as we conclude.
Thank you very much. Millicent Adede, you've asked a question, why can the county governments pay stipends to the CHWs, yet they pay other workers? Is it because they don't appreciate the work they do? My friend, I'm not the right person to answer you that question, but believe me, you not, that without the community health volunteers, then our health systems are doomed everywhere. So with me, I do not agree that the county government cannot pay those stipends. As we've said, it's only that they like looking for loopholes where corruption will take its way. Just as Lucy had been telling us that you form a CC and then you wait for the donors to come and bring the funds. Why can the funds be put into one bag and then be distributed in the right manner? So I agree that all the community health volunteers need to be paid by the county governments. And if we depend on the stipends, or we depend on the non-governmental organizations or donors to give us the stipends, and they pull off, of course, this is 100% that it is not sustainable and it's not acceptable. And thanks to Hakijami, because of bringing up this research, we need to fight, we need to advocate, we need to push until the government, through the universal healthcare, ensures that the stipends are paid to the CHWs.
Yeah, thank you so much, Betty, and thank you for joining us today. Now, Omondi Otieno, if you can hear me, kindly just take a minute to probably conclude or give your closing remarks.
Yeah, I think it's unfortunate Lucy left. I think she left lots of dust. Yeah, but nonetheless, I mean, because I also think it's something I probably wanted to get back to her on, that you cannot, I think it's highly inaccurate that you say that people visit private facilities because of prestige. I think that's highly offensive to people who do so because they do not have a choice. People who visit private facilities because there are no drugs in public health facilities, and that's a fact you can't take away. That there are no doctors, they're not adequate at the very least, that you can't take away. These are realities, and they opt for private facilities because that is where they get, care in a way that is convenient. And obviously it comes at a price. Nonetheless, so I will just shove that aside. So in 30 seconds, I would say that one, I think we must step up, and when I say we, I mean civil society must step up and form and organize ourselves around frameworks for social accountability. We must continue asking these questions. We must ask what the allocation is and its adequacy, what it's used for, and most importantly, how it is used. Number two, partners, development partners must, especially partners in health, needs to be able to, organize themselves to support healthcare in a way that is very, very structured and in a way that fits into an agreed framework with clarity of outcomes. At the end of the day, our healthcare system is weak. We definitely need to invest in it, but the milestone needs to be very clear, and we need to appreciate the journey. Of course, most importantly and finally, increased investment in health. We do not have enough of everything, and definitely there needs to be concerted efforts to ensure that we continue to be able to invest both in human resources and finances in uplifting or making more accessible healthcare to populations that need it most. Thank you.
Thank you, Tieno, and I think you've summarized it so well. Thank you for that. Betty Sharon, kindly take a minute to give your concluding remarks. Betty, are you still with us? Okay. All right, but I think...
Hello? Hello?
Yes, Betty?
I am still here, Brian.
Kindly just take a minute to give your concluding thoughts on the topic.
Okay, my sincere thought is about NHIF. It is so sad that you find in the informal settlement, out of 5 key informants, only 1 is paying NHIF. I think when we go to work, we need to go deeply into why people are not paying NHIF, why people are not interested. And the truth of the matter is that you pay NHIF and then you need to stay for more than 6 months before it is activated. So already you have paid, but you cannot get the services. We need to come up with policies that protect the citizens, and once one has paid the insurance, the health insurance, it should start working immediately. It is so sad that a woman down there who lives beyond $1 pays 1,500 and expect services, but still they are going to wait for 1 year or 6 months, at least 6 months, to start getting services. Illness cannot wait. And when ones have paid, let them get the services that they have paid for. As much as Lucy was defending UHC, UHC cannot pick up when people do not trust and have interest in HIF. Thank you.
Thank you. Thank you so much, Betty. And I think we will end there. Thank you, everyone, for joining us in this conversation. How I wish that the conversation should not stop here, because as you can see, the report proposes 6 recommendations that we now, as CSOs, as various stakeholders, as community members, we need to start thinking about how then do we make sure that 1 or 2 of these recommendations at least are carried forward and implemented. So that is it from us. My email is brian@hakijamii.com, brian@hakijamii.com. Kindly send me an email so I can share with you the report. And also the conversation for today's launch will be on YouTube. So I will also go ahead to send you the link if you need to revisit some of the discussions today. Up until that point, I think I have no more to say, but also only to wish you well in the rest of your day, in your various work, and have a good day. Thank you so much for joining us.